Thank you. If someone can give me a thumbs up from those people joining via Zoom that you can hear me. Oh, perfect. Thank you. Thank you, Ellie. This is William Calo, the director of the Implementation Science Course, and I welcome you all to our first Implementation Science Seminar. I'm very happy to see so many people here in the room and by Zoom. I'm so excited to see 45 people joining via Zoom. This is, I think this is a great success. I'm so excited. Honestly, we have almost 20 people here, so I'm very excited to this seminar and have you all here. So one of the goals of the Implementation Science Course is to build capacity among faculty, trainees, and community partners to advance the field of dissemination and implementation science. And one way to do that is to offer educational and training opportunities. Today's seminar and the ones that we will continue having the rest of the year are a step in that direction to build capacity with our faculty trainees, and hopefully we can have community partners join us in the future as well. So we have a packed agenda today. I'm going to be one moment here with my slides. On behalf of Jane Krasnowski, she has no voice today. That's fine, but she's here with us today. I want to welcome you all to this seminar. This seminar is sponsored by CTSI in collaboration with the Cancer Institute and our Comprehensive Health Studies program. We will continue having more of this in the future, so welcome you all here. I want to introduce our main speaker of today, and this is Dr. Adsul. She is an assistant professor in the Department of Internal Medicine at the University of New Mexico and a member of the University of New Mexico Comprehensive Cancer Center. Within the Cancer Control and Population Science Research Program. She is a primary care physician by training, and after receiving her doctoral degree in public health, she completed a cancer prevention fellowship with the Implementation Science Program at the National Cancer Institute in Bethesda. And now she serves as a consultant for cervical cancer screening guidance at the WHO. Dr. Adsul is recognized nationally as a leading implementation scientist, and today she will share with all of you and us here how she uses implementation science methods to advance health equity in her cancer prevention and control work, both nationally and internationally. So welcome, Dr. Adsul. Please come over. I have help from Gail to change the screen. I will appreciate that.
Sorry, I just wanted to get the next slide. Hi, everyone. Again, thank you so much for inviting me. I really thank you, Dr. Calo and others on the team. This is very exciting to be your inaugural speaker. I hope you take some helpful stuff from my work, but hopefully this builds a really large agenda in implementation science. That is something that I really walk and sleep in. So anytime you want to talk more about implementation science, in a 40-minute talk, I didn't get to squeeze everything in. But hopefully these are pointers towards next steps that you can incorporate in some of your work, but also always feel free to reach out to me as well. So before, you can use it wasn't working, so that's why.
If you can minimize the box on the side, I would appreciate that. Thank you.
First, I would give you a little bit of an introduction about me. I am a primary care physician and grew up as a Dalit in India, which means a untouchable caste. It's a social caste system made very famous with Isabel Wilkerson's caste book that compares the 5,000-year-old caste system in India to Those influences have carried me towards not only to my personal journey, but also my professional journey, which is what has brought me to this intersection of equity and implementation science. I was a Fogarty scholar where I got to take a very innovative, amazing evidence-based intervention and put it into research and practice in tribal and rural India. I'll show you a little bit about that work and learned very quickly I could be the one champion, but if the healthcare system and the providers that I'm working in partnership don't understand the value of this information, don't agree with the value of this information, it's not going to get implemented and sustained in healthcare settings, especially not in resource-limited settings, especially not in medically underserved populations, which allowed me to really hone in on the science of implementation during my fellowship at the National Cancer Institute, which was a really nice way to just learn to talk about these abstract concepts and understand them a little bit more deeply. And then in my current role as an assistant professor at the University of New Mexico, I have been so privileged to work on the land of the Pueblos and the land of the Sandias with 19 Pueblos and 3 nations within the state of New Mexico, and to gratefully recognize their land and to work in collaboration to support and empower them in this work. So as a recent citizen to the United States and a faculty at an R1 institution, it even humbles me every day to work in this context and to be able to provide care and research for them. So with that, I thought I would cover a little bit of a primer of what's implementation science, just help you frame it the way I've been thinking about it for a lot of my research. I've taken a deeper dive in the last few years in truly thinking about how to incorporate equity-oriented research within the science of implementation. And then I thought I'd present a couple of projects just to highlight some of these themes for you as we've been moving forward on them. So you're all aware of this. We're all researchers in the audience mostly, or supportive staff for research, right? So we're all aware of this pipeline of research, making it a priority, making it a funded priority, getting those grants funded, making sure there's findings that can then translate to evidence-based guidelines that can go to populations. And you're also aware of this being a 17-year odyssey, right? And this was like the big critical Ballas and Boren paper in 2000 that evaluated. There is this, how long does this take? Now, in 2021, a very dear colleague, Shanaz Khan, actually now Dr. Shanaz Khan, took upon herself to revisit this from the perspective of cancer prevention and control. So she looked at mammography, clinicians advised to quit smoking, colorectal cancer screening, HPV co-testing and vaccination, to look at this 17-year odyssey and if this was still true in 2020. Any guesses if it was still true? Yes. Absolutely. Still takes 15 years to translate evidence-based interventions into clinical practice, right? Even for cancer prevention and control. And why might this be the case, right? We know evidence that comes from randomized controlled trials is often untested in real-world settings. And it's very interesting to note what gets adopted and what doesn't get adopted, right? So evidence is not applied equitably, right? And many times, and this is very, very especially true for my native community work, it's not applicable or relevant to some of these communities. So they may not trust the evidence as it starts from the first go, right? We all understand, and I'm sure you guys have heard from Dr. Calo several times, context matters is the mantra for implementation science in so many ways. But it then dominates us to think, how can we fit to this context? How do we adapt to this context? How do we ensure that by adapting to this context, we are sustainable and can scale up these interventions? Because hopefully that's the ultimate goal. It's not about this one R1 study. It's about the next step of ensuring it stays in practice. And the 3,000 words in a manuscript don't allow us to really present implementation information, which is really complex, changes by day, like we all are in a dynamic healthcare setting. It changes day by day. And so how do you present that information in an understandable way, which is very complex and is constantly changing? implementation science adopted by NIH in the early 2000s. I think we've had a funding stream since 2007, which presents itself as this science that can study the methods to promote the adoption and integration of evidence-based practices in routine healthcare settings and populations, right? So as to impact population health. And one thing that I always try to distinguish is implementation science is a broad umbrella, but comprises of two different research paradigms, right? One is dissemination science on your right that you see, which is that targeted distribution of information towards the relevant content. But implementation research is really the use of specific strategies. That is what distinguishes it a little bit more to integrate and adopt and implement interventions. The model that has always helped me think through implementation research methods has been the Enola Proctor model from her 2011 paper, where too often actually in our own research, we see what the evidence-based intervention is, and we see what the health outcomes that the evidence-based intervention achieve. But what we don't understand is that black box behind this, right? And specifically the how, the strategies, and how did you get this evidence-based intervention into a clinical practice or into a community setting and achieve some of these outcomes in order to achieve the outcomes, right? So the strategies become like sort of the building blocks of thinking about implementation science, implementation research. And those are the specific methods or techniques that can be used to enhance the adoption of implementation. I oversimplified this for an example, just to give you an example. This is not how many real-world screening studies happen, but consider screening to be your evidence-based intervention that leads to early detection of cancer. And one strategy to implement this might be having your providers provide recommendations to the patient that you're seeing, which might result in an increased uptake of screening tests. And at the service level, result in more efficiency, especially when it relates to when you get providers screening for hypertension, diabetes, and cancer screening. How can we lump that in that recommendation strategy that allows for all of these to be efficiently delivered in practice? Now, if some of you are familiar with the D&I world, one thing we have is a ton of theories, models, and frameworks. But I wanted to take a minute to just tell you why that is the case, right? Like I showed you earlier, there isn't enough information in published papers and research and white papers and literature around actually the implementation and the strategies, right? So there hasn't been enough data that has accumulated to tell us exactly how implementation works. And I think that is the reason, and especially again, if you lay that over with the context that's always changing, that we don't really quite understand very well, then you start seeing why the reliance on theory, right? That is the reason why I think many of the implementation projects always are trying to do this trifecta of empirical data, providing some context, and getting a theory in there, right? And so that allows you to then start building, okay, this may be what implementation might look like or might happen. So hopefully having theories, models, and frameworks helps build more justification for a focus on implementation science. And there's an amazing tool out there, which is actually just fresh off the press, is getting actually modified. This is a website that presents dissemination and implementation models, theories and frameworks. And on the colorful left side, you see if you wanted to plan for implementation, these are the theories you would use. If you wanted to adapt, these were the theories you would use. It actually stratifies it for your use. The heart of the press thing that I was going to tell you is this actual whole website is being right now modified to incorporate equity theories within it, or bring out equity-related concepts within each of the implementation theories. That's coming, I think, later this year. We're all very excited about sharing it. So despite this background of implementation science, there has been, and it has been specifically highlighted in our 2020 ongoing COVID pandemic, around the inequities in implementation of evidence. Right? Black patients are less likely to receive certain cancer treatments compared to white patients. The large UNC trial showed this. There have been studies that have shown like less likely to access medication. Black and Hispanic patients were less likely to access medication-assisted treatments, not only during the pandemic, but also prior to the pandemic. So some of these disparities actually have been exacerbated due to the pandemic. And then we saw several reports after reports for COVID-19 pandemic showing differential outcomes, disparity outcomes in regional and minoritized groups. And just to level set ourselves, when I say health differences, these are just population subgroup differences, right? But when we start using the word health disparities, there is a social justice component involved in there, which shows you that a group is disadvantaged socially and justice oriented to provide an advantage or to have another advantage for another set of populations. But when we start talking about equity, what we are really talking about is that underlying principle of ensuring everyone has equal access to care, right? So what that means is a much more a solutions-oriented paradigm versus what we talk about in disparities research as in identifying or understanding differences and understanding where the social justice issue is, right? But equity really tells us what are the solutions that we are bringing forward so that everyone has an equal opportunity to good health. So implementation science over the past few years has really embraced itself as an opportunity to include equity in work that they are doing as implementation science communities, both in terms of research processes as well as in terms of outcomes. And last year, we were able to sort of provide some additional thinking around this space in really grounding implementation science and equity for cancer prevention. And much of this work actually was led through the Cancer Consortium for Implementation Science, which if you guys are not familiar with, I highly encourage you to participate in that meeting, which is a very high level brainstorming meeting, allows you to kind of see more implementation science from the perspective of some of the thought leaders in the space. What we were able to present in this article really is strong arguments around how health equity should be foundational and not just explicit under the category of reach. Well, are you reaching the medically underserved populations? Are you reaching the resource limited settings, right? That's when you start thinking about equity. It requires reflection, accountability, and focus on health equity and racism, which is an underlying principle of so many of our inequitable issues. We also make the case to prioritize evidence-based interventions that can help address racism and mitigate its impact on healthcare systems, while we are also thinking about implementation. But we are not the first people to think about this as implementation scientists. There is a long history of equity work, community-based participating research, translational research that have been doing of disparity scholars that have been thinking about this. I think it's an opportunity to join forces rather than reinvent the wheel around what we think is equity in implementation science. And then by the choosing of our specific settings or our specific population that we work with, are we being careful not to exacerbate some inequities, right? Because that is a very easy. We do not pay like if we do not pay attention to it, we can the case. But start doing in this paper really presents some concrete opportunities for articulating explicit focus on equity in reviewing and conducting implementation science, both from a funding and from an applicant perspective, making sure that they are equally incorporated in these models and frameworks. That is why I was excited to tell you that this tool is happening. So this was a direct recommendation made in some of these papers that actually helped them get on this agenda. And then identifying methods for understanding and documenting what we mean by context, because context can be so abstract in so many ways, but being more concrete in like defining what it means for this particular project versus others. And we totally understand that doing all of this work is not going to happen in the current systems that we live in and operate in, right? So how do we build capacity among researchers? And yours is an excellent example in building capacity. But how do we bring equity-focused work, community-engaged work together with implementation science and incorporate these considerations across all key implementation focus areas, including adaptation, strategies, study designs, outcomes. And then learning from each other in cross-disciplinary and transdisciplinary opportunities for equity and implementations. We've been very cognizant in calling out specific recommendations, for example, in terms of structural racism, which is one of the fundamental drivers of social and health inequities. We've been talking about a multi-pronged approach over here, in that not just including it in our theories and measures, but making sure that all projects, all research is driven from a multi-level thinking, because structural racism operates through these interconnected systems and creates system level inequities. So if we only focus on the patient or the provider, we're missing the system level opportunity to think through some of this. And that.
So we're getting a lot of messages in the chat about it.
Should I shift here?
Yeah.
Instead? Oh, no, that's good. Is this better? Is that working better? Maybe the microphone is here. So I don't get to see all of you. I'm shortly here.
Much better.
Much better. Okay,
Thank you.
awesome. So not just thinking through the multi-level aspects, but health doesn't operate only in its silos, right? So that how do we broaden a multi-sectoral thinking, because that's how structural racism can ultimately be addressed or even thought through. We haven't even understood intersectoral work through our own focus only on health. If we are truly to move towards that equitable health paradigm, then we really do need to open up intersectoral collaborations. And the other aspect that we focused on is racism, which is, again, a fundamental aspect of social context, yet does not show up in any of our frameworks and implementation science. We know it operates across interconnected systems, but by not considering a role of racism, are we leading to inaccurate explanations of context actually? Or are we thinking about them in a way that actually can be addressed in future research, right? Because we are completely missing collecting information around racism in any of our contextual implements. So we put out this piece that really helps us as researchers consider the context of which we bring forward from a research context perspective, and how could we incorporate it within all of our elements of implementation research, beginning from stakeholder engagement into our theories, models, and frameworks, in the development, selection, or adaptation of evidence-based interventions through evaluation and selection of strategies. Over the last year, I've also been very fortunate to work with this large research network called the Cancer Prevention and Control Research Network through their Health Equity Working Group, in which we talked about some of these larger principles that have been guiding a lot of our work and commitment towards cancer prevention and control. And there's been a lot of efforts from CDC that have guided a lot of this thinking from a practitioner perspective. But what we thought was missing is, what should researchers be doing there? And so we were able to work together as a group and talk about, as a large, amazing group that I've highlighted here, and talk about identifying specific research practices that would help us achieve some of these equitable outcomes. And I see cores and centers like yours being really well positioned to use some of this work. This is a freely available resource on the CPCRN website to say, how can we start as researchers doing this more equitably in our work? Yeah. So with that background, I want to turn to more examples and wonderful pictures rather than the boring didactic around implementation science. And I'm so happy to share with you some of my work as a Fogarty scholar, building some of this work around cervical cancer screening in rural and tribal communities. This was very much in partnership and used a community-based participatory approach with the logo that you see on the right, lower side, the Public Health Research Institute of India, which is a small community-based organization led by 27 amazing women that have worked for the past decade to improve maternal and women's health in this space. And through their partnership, we were able to actually work on a project on an issue that was problematic for them. And that was, they were providing free of charge cervical cancer screenings in the community for a decade. And over the years, we're noticing less and less women were coming to access these services. And so this really drove them to come to me and say, like, can you help us understand why this is the case? I thought the biggest barrier in India was not having access to the clinic and not having money to pay for the clinic. And you would think that, right? Like we would think that sitting here, yeah, if we can provide access, people will come. And that's a very common saying in implementation, see the science talks, if you build it, will they come? And this was a great example for me to sort of start my work or contribute to the work, the ongoing work of this institution already in the community. We worked with multiple stakeholders, like women from the community. We actually did a photo-wise project with them to truly go beyond those traditional barriers that people mentioned, time, money, and access. We wanted to really go and dig in deeper and understand why is it that women do not see these services. And that's when we started learning lessons like HIV and HPV education get intermixed with it becoming a sexually transmitted disease. Folks were worried that when the woman gets tested in the community, that their infidelities might come out. And so it was actually backfiring by doing and promoting a lot of HIV and HPV education in these communities. The other thing that we realized also that women in India are not the healthcare decision-making individuals. They do not make decisions for themselves. They make decisions for their children, but they do not make decisions for themselves. The people who make decisions, the referent population, is their husbands and their mother-in-laws. So if the mother-in-law comes and tells you, I never got a cancer screening, why the heck do you think the woman would go and get a cancer screening, right? So these were sort of the themes and understanding, a very, very deeper understanding of why a service that you're providing free of charge may not work in the community if you don't incorporate some of these messages that are important for the women, right? We also did a lot of interviews and understanding from physicians and community health workers, which provided similar sort of themes, but also sort of talked about a lot of challenges in the healthcare system not being oriented towards prevention care. You can imagine it's a 1.21 billion country. Not enough physicians will ever be able to provide all the care that is needed in the country. So much of the focus goes towards symptom-based care versus prevention-oriented care. So there's not enough time, resources, and energy left once you provided the symptom-based needs in the community. So with all of this understanding, we were able to go back into the community and say, hey, if we didn't need this much of work in the community around conducting these pelvic exams and getting everyone screened for cervical cancer, could we actually feasibly implement self-sampling as an approach that we could go take it to the community and see if this works, right? So that's where our innovation, evidence-based intervention from the West was coming in. And I was like, so excited. I'm like gonna go work with, we were able to actually do this cross-sectional study with 500 women in some of these quote unquote hard to reach places, just not reached places really. In that we were able to also get 70% of these population from the lower castes that typically are never included in urban healthcare delivery services. And typically, actually some of them, I want to say at least 40% of us, 40% of the population told us that they'd never be into any medical setting ever. So this was our approach, a very community-driven approach. So going out there in the community, doing these health educations, doing these tablet-assisted data collection, which was really cool for our research staff to sort of try out and do, and was very successful in this project. We actually administered 100 questions in these tablets because we did not just focus it on cervical cancer screening, we went all out. We did blood collection, we did triglyceride levels, we did hypertension, we did HbA1cs for diabetes, and we did cervical cancer, as well as breast and oral cancer examinations. That's me trying to be useful, but not speaking the language, but at least could run the BP machine, right? Like, so they made use of me, but you can see in the background, this was a system that we did in an actual school setting, which was the only setting that had running water in the community. So we wanted to make sure that was available as we did the blood draws, as well as did the self-sampling for cervical cancer. And this was a 2016 study, right? That's when we were able to show self-sampling. And guess what? In the United States, we still do not have access to self-sampling here. So it's a really, really frustrating part for me some days to be able to do this. But as we did some of these screenings, that's when we started to run into the challenges associated with an evidence-based intervention that is multi-step, right? So it's not just giving screening to these women. How do you follow them up appropriately? And then now you start getting into these complex algorithms and complex ways and multiple providers and multiple settings that have to be all aligned and all in a referral pathway that can give you exactly the appropriate care that each woman, each individual seeking the screening service deserves, right? So you see, you know, I started losing people all over. I started losing follow-up rates. I started losing referral rates. We were fortunate to, we realized a group of women that we worked with were migrant workers. So seasonality dominated how we could follow them up. We could not come back and do the work that we needed with them in terms of follow-up. This is the point where I realized implementation science was my field. So it's like, I really need to I cannot go in full consciousness and do any other screening study if I'm not going to be able to understand how to do follow-up and treatment and appropriate reception, right? This was an amazing experience that has now led me to collaborate with the World Health Organization on the global strategy for accelerating elimination of cervical cancer. And just to give you a snapshot, the strategy actually involves vaccinating 90% of the girls, screening 70% of the women, and then you see 90% of the women identified with disease should receive appropriate care. So this again becomes a screen diagnostic treatment pathway that they're trying to implement for eliminating cervical cancer. I was fortunate to work with this larger working group that was creating guidelines in 2021 for cervical cancer screening. That complex algorithm that I showed you was one of the algorithms they were trying to simplify and finalize in these guidelines. But as they were doing so, a group of us was able to kind of promote this idea that as we promote more screening and treatment, this might be the opportunity to actually shift our paradigm from newer diagnostics, newer treatments, to actually saying what works under what conditions in what settings, right? So how can we shift to adoption, implementation, and sustainability of cervical cancer screening programs, which will require a focus on readiness of the health systems, focusing on equity as we incorporated within the REACH, and focusing on stakeholder engagement as we try to promote these guidelines in different contexts across the globe. So very fortunate to be working with the Deputy Director for NCI Center for Global Health with WHO partnership that are together committed towards driving an assessment of implementation strategies and context within this space. So what we propose to do is actually talk to program managers, physicians, administrators, policymakers. And if you notice the theme over here, it's the practice folks. Forget the academic folks, right? Let's go to the people who actually do the work on the ground and know the complexities of getting things done and ask them what has worked and what hasn't worked in what settings, right? We chose to work with all 6 of the WHO regions and worked with the WHO regional advisors in this. And the key questions we were trying to understand over here is, under what implementation context within the different countries are cervical cancer screening programs being implemented? And then based on experience in that country context, what strategies help adopt this program, help implement, sustain, and scale this program based on both quantitative and qualitative work. So we did these theory-guided interviews and really dug in deep. Like, these were 90-minute interviews with each of these program managers that was just telling me, so how does the patient go from getting the result? Like, how does the individuals get the result? Once they get the result, who gets the next appointment? Who helps with the next appointment scheduling? Once they get the appointment scheduled, how do you follow up and track them in your registry if you have one? Right? Like, so we tried to really get down to the practice of how things are getting done in the countries. And we included like participants you see across the globe from 25 countries that were these community practice experts. And here's the inductive analysis that we were able to like sort of create from all of these strategies that we talked about. So on the bottom, you see the exploration, implementation, preparation, and sustainability framework really guided some of this. Like, what are the things that you do in exploration phase? What would you do in preparation phase? What would you do in the implementation phase? And then for this phase, in the colored boxes, you see that there are certain strategies that were specific to promoting uptake among individuals, the women in the community, specific strategies to ensure retention in the pathway from screening to diagnostics, and improve specific strategies to improve acceptability among providers. So it's not just the women that need to come to this program, it's making sure that the providers are also engaged in the program, promoting national adoption by the national public health system so that it's integrated within sustainable architecture, promoting implementation and scale up again within the national system, and then having global implementation support. The cost of an HPV test still remains a big debate. It is really costly for some of these countries to adopt this in a national system. So how do we have some strategies from global experts that can help implement these programs? And so now you start seeing it's a very multi-level problem and has specific strategies based on what level you might be working with within the health system. Okay? And this is just for an example that I showed you. This is a very detailed analysis of like the first box is strategies to promote uptake. These were the 11 strategies that we saw from all the 34 interviews that people had been using. For example, community health workers were a strategy to implement to improve uptake from women, right? Having print materials, having peer networks. So you see, we're starting to then build an understanding of how implementation actually happens within these countries and within these contexts. Similarly, we looked at ensuring retention. I don't know why this slide has been given, this is so finicky. Sorry, you're not seeing those two boxes filled up, but we had a total of 9 strategies over here as well, or 10 strategies. That allowed us to talk about how do you ensure retention of the women across the continuum, and then strategies to improve acceptability among the providers. One thing that you're seeing on the left side is an additional understanding of context. So let's take like number 5, in-country stakeholder engagement. We needed, a lot of our participants actually told us that in order to improve acceptability among providers, you really needed the national folks, the national equivalent of American gynecological societies or American or national professional organizations to be on the table when you are improving acceptability among providers, right? So having a national plan would help with some of the implementation was the strategy that they were saying would improve acceptability. Does that make sense? So like we were trying to really get into the nitty-gritty of strategies space. All of this work actually has really influenced a lot of my own research, even in New Mexico. I didn't bring this up in slides, but I was telling others I would mention it. is we are doing similar work with LGBTQ plus individuals in New Mexico, informed with some of these strategies, informed by some of this thinking, and actually implementing a self-sampling driven approach for the subgroups within the LGBTQ umbrella that might help as well. Last project that I wanted to just bring up, and this is more in partnership with lead PIs from our UNM Cancer Center, funded by the Moonshot Initiative. This is a project around accelerating colorectal cancer screening through implementation science. And we are a smaller consortium, which is the American Indian Consortium in partnership with Arizona and Oklahoma. But we are working with key partners within our community, which are tribal, like I mentioned to you early on. We have 19 pueblos and we have 3 nations within the state. We're working actually with 3 of the pueblos, which are the tribal communities, with separate languages, with separate understanding of community context within that. That is very much in close partnership, and again, using community-based participatory research approaches. And our key facilitators over there are the Albuquerque Area Southwest Tribal Epidemiology Center. These are individuals that were funded by CDC to be specific epicenters within tribal populations that have led for decades work to improve the health of tribal communities through epidemiological guidance. And so these partners have been very critical, and I always have a smile with this slide because it actually shows one of our community members flexing their muscles to be tough to get screened for colorectal cancer, right? And with the goal of increasing screening uptake among these communities, we've presented a hybrid study that allows for the exploration of implementation outcomes as well as intervention outcomes within these facilities. What was amazing to work with is through the facilitation through Aztec, we created these teams called multi-sector action teams. And on the bottom, you will see what they mean is not just calling out the physician or the nurses, but working with the mid-level providers, the community health workers, the case managers, the behavioral health, pharmacy, laboratory folks, to work together as a team to improve cancer screening rates in these facilities. I don't know if everyone knows, but the Indian health system is basically a budget line in the Congress plan. That's a leftover budget line. It's not always a consistent budget line. So what that means in practice is that from year to year, your budget is going to be different and how many people you can retain on the staff. And so that was a necessity to work within this context to ensure that multiple people were working with us and not just one single provider at one time, right? This project would not have, any of it would not have been possible if you didn't have the facilitation provided by Aztec, right? These are the people that the communities recognize, have been working within the community for 10 years, and we were able to partner with them to do this project. So the facilitation provided by them was very, very essential. And then finally, I've gone backwards on the slide, but I wanted to also highlight the formative research, which was very, very critical in understanding some of the concepts that I abstractly presented to you in the first half of the presentation. That's where we started seeing, what I just told you, how IHS funds this healthcare system is an important part of the context that we have to understand if we are to incorporate it within our implementation efforts, right? How the formative research also revealed very in-depth understanding of our Native American communities, where the way the healthcare systems are designed provides access to the community, but the entire state of New Mexico can get access in that community. So sometimes that access pushes down the access for the actual tribal community members. So that's where the mistrust and the distrust for the system really starts coming up. And if they're not going to trust the system in which you are putting in all of your implementation efforts, without addressing the trust in the community, you're not going to be successful in showing any outcome change. Forget intervention or implementation, right? Or even if you are, they are not going to be sustainable outcomes for one time point. So these are the sort of the approaches that have helped our study really be grounded in making sure that we are equitable in our implementation and intervention study. Very briefly, you will note that I cannot share raw data or data around any of this till I have tribal approval. But I just wanted to highlight some key findings that we've seen. We see it as a very big win that we've sustained these multi-sector action teams through the 3 sites. You'll notice it's 3 sites and not 4 sites. The 4th site, unfortunately, has not recovered from COVID impact at all and has lost a lot of staff and elders within the community and has just not been able to participate in cancer prevention efforts yet. But we've sustained the multi-sector action team in 3 sites across the pandemic. So this started prior to the pandemic and we've been able to sustain it as we're seeing it now. Male fit reminders are a very hugely driven evidence-based strategy across the US, do not work in Native communities. We do not have post boxes. We don't have mailboxes on the reservation lands. We access them with personal PO boxes in the mail offices, in the post offices, but they do not, they get trashed. We found all of our fit tests trashed in the trash can because they were not understandable. Nobody understood it. Nobody was in the, we did have a little bit of success when the federal checks were coming in for the pandemic, but we could not achieve that success in the next mail out. So that's a reality in the community that we work with. It's not an individual house level mailbox. But what has worked in our context is pharmacy dissemination because they come back for refills. So that is a nice opportunity for them to get a fit test. What has worked is community health representatives, which are community health worker equivalents in these settings, to do some home delivery and education around this. And a very great example we went through in the last fall that I think is an example of a sustainable incentive. I'll see what you all think. But we gave out turkeys and hams for Thanksgiving and Christmas. And that's what showed that jump from 25% to actually right now 50% screened in this healthcare facility. And I know you're thinking, this is not sustainable. How can we come up with $60 turkeys and hams every time? But guess what? This community is a food insecure community. There is one grocery store in a whole radius. So for the medical leadership of this facility, by distributing turkeys and hams, they thought they were achieving 2 goals at one time. So it became actually a very sustainable incentive that they have promised to continue even after the grant period ends. Well, they've promised. And I do think because of the food insecurity being a big priority for the system, this will continue in so many ways. We are just excited to see what happens in the next couple of years. Just quickly, this has also allowed us to do some trans-access collaboration. So I said this is a part of a research network that's doing it across Chicago, Kentucky, North Carolina, San Diego, and Oregon. And what that has allowed us to do, and this was a presentation we actually submitted to the DNI conference last year, but essentially looking at all of the access sites that are participating in this research network and saying, can we start developing generalizable knowledge around these strategies, right? So for example, the one on your left is when we looked at all of the implementation strategies being used in access projects. For example, that I showed you in New Mexico, we are using CBPR approaches. We are using incentivization of fit test. We are doing pharmacy dissemination, those strategies. We looked at all 8 projects. And what we start seeing is that most strategies were influencing the healthcare setting. Screening was the focus of many strategies. Sorry, let me go back. Most strategies were influencing healthcare setting, but very few were influencing community level, right? Screening was the focus of many strategies, but guess what? Treatment and follow-up was not being addressed as well, right? Many strategies focused on that preparation and implementation phase, but not as many on sustainability. So this is how you start seeing more generalizable information around implementation strategies that are being used across research networks. So we were very excited to get to talk about this at the DNI conference last year. I just want to like close out. I'm sorry, I've taken you from the globe to New Mexico to like all over the US. But I just want to wrap up and say, you know, implementation science really for me has been that opportunity to provide an infusion of equity orientation more strongly, more deeply within all of the efforts that we do. Whether it is through engagement with the communities receiving the interventions and including the providers in such work, whether it is through tracking and sharing and utilizing some of this generalizable knowledge and understanding concepts, context and adaptations during these process on a larger level so that we now know where to begin with. And then the next 10 years of my agenda are focused on how do we become more equitable in our reach? How do we ensure costs and sustainability is at the forefront and not at the end of our research projects? With that, this takes a village from our research collaborators, our research partnerships, and participants to training opportunities that Jen and I were a part of at the Cancer Prevention Fellowship. A lot of my work around racism and structural racism came from some of those collaborations, the WHO and the Moonshot funding, and then of course our UNM Cancer Center who's providing the support. Thank you so much for your time.
Amazing. I just want to say thank you for this amazing presentation. Gail, if you can help us here putting the slide, if you can figure with me for the Q&A. We have 7 minutes, so I just want to, any questions from the audience? I want to start with one. In your experience, what are the top priorities for the field of D&I relevant to cancer research? You mentioned a couple of them. What do you think? We have been talking a lot about the implementation. What do you think, where is most of this research needed?
I think it's a very, very nascent field. I think we are borrowing a lot of D&I concepts from mental health and behavioral health still. Cancer prevention and control is a smaller field that's growing. But thinking about the evidence-based interventions that we have currently that we know work, that's where I see the hotspots for a lot of D&I research in cancer prevention. Screening, vaccination, a lot of physical activity, diet, lifestyle interventions for cancer survivors. You know, those are the areas that I see are more going towards implementation in different contexts, like community and knowledge practices, for example. We have very limited literature about D&I efforts in community and knowledge practices. We have very limited literature around cancer screening and preventing of care settings from an implementation point of view. And then again, specific subpopulations, right? We talk about these large Kaiser Permanente driven studies that have big reach, but we haven't done enough job of like understanding small populations within that to be able to promote an implementation focus from an equity angle. And yes, de-implementation is a really interesting topic, but very focused right now on things like pap smears that we want to de-implement so that we can promote self-sampling and HPV testing. There is a lot of work in Canada around unproven practices or pain management and back surgeries that they're doing. I haven't seen enough really.
I know our own Jennifer Moss is working on a project about implementation of mammography screening among older adults. I just want to ask any of our 57 people in the Zoom right now, if there's any question from you guys, I would like to hear from you. Please put any question or comment that you may have in the chat, and Rebecca will answer that. I have any question from the audience here.
I did want to just build upon that answer really quickly as well. In addition to content areas, I think methodology. D&I is very interested in large studies that can track these strategies across many projects, similar goals, So I think we have to build that evidence base for implementation. That is a very hot topic that many people are focused in on. Sorry.
Right, I have thank you, Jean. I have a question here. I find that there are issues with implementation that stem from differences in clinical recommendations, or in changing recommendations. Do you see that? And if so, how do you do that?
That's a very, very important topic. And I think Jen is doing exactly that with her mammography study in ensuring the newer recommendations are what are promoted in implementation versus the implementing of older recommendations, which is exactly the pap smear stuff too, where we are trying to make sure people are not throwing the baby with the bathwater, right? Like that not all wellness exams for women are excluded, but then how can we improve some of these highly accurate tests and their implementation within the clinical
I think
setting.
something that we're seeing also in the HPV space, with ACS recommending vaccination now at ages 9 and 10, and CDC is dealing with recommendation at 11 and 12. We're seeing a little bit about, what is the actual preferred timeframe for implementation of best practice.
But I think adaptations as a field, de-implementation as a methodology could be very helpful in figuring out some of these processes and how for the age 9 recommendations, we just put forward a piece that was like, can we take existing interventions and just adapt them to include age 9 instead of age 11 for HIV vaccination? And I think so there are all these opportunities to get that studied within the framework of it.
Any question from our audience here before we move to the flash talks? Yes, one question here.
Hi, my name is Pradeep Gross. That was a wonderful presentation. Thank you very much. My question to you is, do you have a preferred implementation framework?
Oh, gosh.
Let me repeat the question here for everybody. So if there's a prepared implementation framework, I would like to hear that because there are more than 100 of them.
One.
81. I think, just Fresca, go just let's go with that question.
A very good friend of mine, Anna Bauman, says this all the time. Theories, models, and frameworks are like toothbrushes. Everyone has one, and nobody wants to share it. But I don't have one.
Or the one that you use more frequent, for example, me, I use Cipher. I know Jennifer Moss is Cipher. We also use a lot of Proctor. More recently, have been doing EPIs. If you look at the catalog of RCTs funded by NCI and Picori, you see some trends there. Anything that you're using the DMOS or any new TMF that you think we should be paying attention?
Yeah. I've used all of them depending on the context, especially when they are facilitation driven approaches. I've used the IPADIS framework quite a bit. And one framework to pay attention to is the health equity implementation framework within that space. Eva Woodward has led that work and has provided some practical implementation guides to use the framework as well. But there is, I really go back always to Proctor's model because my work is very focused on implementation strategies. So that has been my way of explicating those strategies quite a lot. But CIFAR is a great determinants framework. If you are doing formative work, then you're trying to generate an understanding from CIFAR.
Yeah, I think the point here was for review is that what is the main goal of using the framework? So if you want to evaluate or lead a process evaluation or just understand implementation outcomes, when you sort out that kind of a question, it will help you to guide to what is the preferred TMF. One final question here in the last minute before going to the next session, and these were our flash talks. And I ask you all the people in Zoom to stay here because we'll have some flash talk from our faculty and trainees here. This is from Sarah Cholinsky, who's going to be giving a flash talk in a moment. Multisectoral teams is an answer that we also employ in community prevention and health promotion work. Can you talk more about those teams as a solution? I think you mentioned something about that.
Right, and that's exactly why we started with that approach, is because it was not sustainable to only train 1 or 2 providers or folks in the clinical setting. You really have to train the whole setting. No 1 or 2 people that understand colorectal well, and then the other people don't, always impedes eventually in implementation. So some of our initial training sessions were actually all of that, all of the folks involved in the medical team. That itself becomes a sustainable strategy with brief, short trainings to refresh their memory from when we started the initial phases of the trial. So yes, I think they are very sustainable.
Thank you so much. If there's any other question, I'll handle that to Rebecca so she can answer during our flash talk. So like a block. Now, Gail, if you can put the slide deck, I want to just have our Senior Associate Director for Population Sciences to lead the second portion of our seminar.
Thank you. I'll stand here with that microphone so people can hear me, hopefully. Thank you, Dr. Adsul, for your amazingly fascinating and very important research and for sharing all the work you do in the implementation science space with us here at Penn State. So now we're going to transition. We have 4 flash talks. Okay, and our first flash talk is by Lauren Jody, or LJ Van Scoy, who is a professor of medicine, humanities, and public health sciences, co-founding director of the Qualitative Mixed Methods Core, and practicing pulmonary and critical care physician at Penn State College of Medicine. Her research program includes theory-based approaches to assessing communication quality and behaviors related to end-of-life conversations. Dr. Van Scoy is a PI of an NIH-funded R01 Mixed Methods project involving a 75-site cluster hybrid randomized controlled trial examining the efficacy of advanced care planning tools in underserved communities and implementation outcomes. Thank you, Dr. Van Scoy.
Great. Well, it's gonna be hard to, why did I bring my phone up? It's gonna be hard to go after that amazing talk. Thank you for such a great presentation. I am going to talk a little bit about some of the work that we're doing at the Project Chalk Trial, which is a project that is very near and dear to my heart. Am I clicking at him? Something doesn't work right. Is she working? Or the mouse? Oh my God. There you go. Oh, it works for you. Then you can say that. All right. So just since, I only have 10 minutes and I want to really focus on my implementation and the aspects of our project that involve the topics that we were just talking about. But since I recognize that many of you may not know a whole lot about advanced care planning, advanced care planning is the process of thinking about your preferences, priorities, your wishes, should you become critically ill or terminally ill, and writing and documenting your wishes in an advance directive to help those loved ones, family members who may have to make decisions for you if you're not able to do so on your own. And historically, this has been a big problem because back in the 70s, 80s, less than 25% of the United States completed advance directives. And in the 90s, there was a big push in federal regulations around hospitals having advanced directives. And we saw that increase up to 60% of white Americans having advanced directives. But unfortunately, we haven't made progress in our underrepresented communities like Black, Hispanic, Asian, and many other underrepresented communities. And that's where we're working in our space. The reason that people don't do advanced care planning is kind of obvious, right? No one wants to talk about end of life or death or dying or any of those things. But besides the reluctance, there's also people don't have opportunity, they don't have context, they don't know how to have these conversations. There are cultural norms and stigmas and taboos that disempower folks or make them feel like they shouldn't or can't talk about these issues. And of course, more recently, well, maybe not more recently, but more prominently, we're talking about equity, a lot of healthcare distrust around issues that have been, historical problems in healthcare delivery. And all of these things, along with resource limitations, leads to a need to bring advanced care planning interventions into our underrepresented communities. And so for the last 9 or 10 years, I have been studying a game. Yes, it's a game about end-of-life issues. It is called Hello. Previously, it was called My Gift of Grace. I did not create this game, although I wish I had. But some very smart people in Philadelphia created this game, which is a game that involves open-ended questions with booklets and game chips and rules and structure. And we've tried it out in lots of different types of communities. We've done volunteers here at the Med Center. We've been out in South Asian Indians in Texas. We've been across the US with Black communities, and everyone really found value and engagement in this tool. And so that is why we've continued to do work. So now in our big R01 trial, we are conducting makes me shiver every time I say it, but a 75-site cluster randomized controlled trial. Yes, my team is here and they're online, which is fantastic. Testing 3 tools. One is a standard tool called the Conversation Project. This is a tool that really doesn't have any implementation or evidence base behind it. It's a marketing, it was sort of a marketing campaign. It was created by Ellen Goodman at the news at ABC. I remember where she was, it's a think, pair, share, didactic, PowerPoint slides, community-based driven intervention to bring advanced care planning to communities. It's a great tool, but it's not gamified. It has a very sort of straight structure with slides and PowerPoints and think, pair, share, that kind of thing, which is of course quite a contrast to the Hello game, which is gamified and uses game design theory. And we have a control arm, which is a game we play around our kitchen table called Table Topics, which is very similar to the Hello game, except instead of questions that get you thinking about end of life and advanced care planning decision, it asks questions like, what's your favorite, what's the favorite thing about your hometown? So it's a really, really good attention control behavioral science tool. So what's unique about our project, and I was doing implementation research before I even knew implementation research was a thing. In our very early days, we were doing qualitative interviews with hosts and different people for whom participants, playing the game, doing work out in the community space. And what we were learning was that people really trusted their community members, right? And so advanced care planning interventions in general have been in the healthcare system, but we wanted to try it out in the community setting. And so we partnered with a wonderful organization called Hospice Foundation of America, and they have been working with us for over 8 years. And we have this, what we call community-based delivery model. And what the model does is it puts the researchers at the top of the sort of, not the top, but the sort of guiding the study to begin. Of course, we have community engaged partners in that process as well. And then we go out and we recruit hosts. And those hosts are people who are out there in the community, whether it be a pastor or a hospice nurse or someone from the local church or whoever it may be. And they are champions for advanced care planning. And then they go out and they recruit a venue, a church, a senior center, a public library. We've been all over. And they go out there and they get us the venue and they invite their constituents and their people to, that trust them, that know them as a familiar face, which is so important in implementation and community-based research. So they go out and then they bring the participants, and that's where we get introduced and we can ask and invite them to participate in our research. So that has been a very successful approach in the general population. And that was the strategy that we utilized for our cluster trial. We're so proud of this map. Our team has been all over the country. Each one of these pins is a site that we've been able to travel to or have been to or plan to be to. Each of these sites, we host very small events, anywhere from 20 to 50 people. I guess it's not that small, but it's meant to be very, very community driven. And while it's very, of course, expensive and resource intense to get out there, what's wonderful is that we are focused only on underrepresented communities. So we're out there with rural communities, Hispanic communities, African-American communities, low-income white communities. And so this is sort of where and each of course are randomized to receive one of the 3 interventions. And so the research design, I'm going to focus mostly on the implementation aim 3, but of course, this is a hybrid trial. So our primary outcome is, does the intervention or whichever of the 3 tools they get, does it help people to complete advanced care planning documents or talk with their loved ones or their clinicians? And this is obviously, we're in the Cancer Institute. And so this is something that's really, really important for us to be thinking about in patients with terminal illness, particularly cancer, because these are the topics for whom it's most salient and interventions haven't worked in the past. And so we're really excited about trying to get these patients who, or participants, I should say, individuals from all different walks of life, completing documents when they may not be doing so otherwise. Our second aim in our project is really looking at how the sociocultural environment. So in I wrote these aims before I was well versed in implementation, I would say. But we're really looking at the inner setting and the outer setting here, mainly in the inner setting of the CFR implementation guide, or strategy, which I'll show you in a moment. But we're really interested to know how is it that the 3 interventions work in Black populations versus rural populations versus Hispanic populations? And so we're powered to do subgroup analyses in all of those different areas. And then of course, across the entire interventional space, we're interested in implementation aids. And that's what I'm going to focus on in my next slide. So my favorite framework is the CFER, and the reason I love it is because it is very detailed and it has a lot of opportunity to probe at qualitatively and with questionnaires. I'm a mixed methodologist and co-direct the qualitative mixed methods core. And so it's really important to me to be able to use a mixed methods approach to implementation. And so we love doing our qualitative, and I'm not going to go through the whole thing, but you can see here how we've been using in our study the CFER constructs, or I think William calls them domains, I call them constructs. That's okay. In my class, I call them constructs. But things like complexity, adaptability, advantages and benefits, and costs for the intervention characteristics. In our setting, we're looking at networks and communication, compatibility and culture. And you can see that we have specific interview questions that are geared at each of those domains. And we have quantitative questionnaires that sort of converge and are matched. For those of you in the mixed methods course, which some of you are in the room, we have some matching going on in our convergent design here, where we're using quantitative questionnaires as well as qualitative questionnaires to get at some of those really important domains. The one that I'm most excited about, and I'll just mention quickly, we're working in Alzheimer's patients, but we're really hoping to get into cancer patients around adaptability. Because what we've learned, we're out there, we're running our big R1 out in the community across the US, and it's not a disease-specific approach. So we have lots of heterogeneity of the types of folks that are seeing our tools. And for the game in particular, we're starting to get the hypothesis that our approach to using the tool in the community needs to be different for patients with, let's say, Alzheimer's or cancer than it needs to be with the healthy volunteer. And so when we have done some pilot work I collaborate with Dr. Michael Hayes, who has used the Hello game for patients with cancer at the cancer retreats. We've learned that there needs to be some adaptation to the tool. And Erica Van Dyke, who is here today, our program manager, is out there working in populations with Alzheimer's disease or mild cognitive impairment. And what we're finding there is that our community-based delivery model isn't working so well out in that when we're trying to get patients with mild cognitive impairment. And so this is my final slide. And I just want to say this is sort of where we're going, and we're super excited about the direction of, and sort of like Dr. Adsul was saying, doing research around how we do implementation. So what we're interested in looking at now, based on what we've been learning in our trial, is it the case that the community-based delivery model may work for some groups or disease agnostic settings like churches versus things like Alzheimer's disease or cancer populations, where we need to be in the healthcare system, and that's really our entry. And are there ways to sort of use what we're learning from the CFER and our implementation findings to actually do a randomized, one day, hopefully, a randomized controlled trial looking at the tools in a cancer population, which is what we chose to focus on, in order to look to see how community versus healthcare delivery and implementation is different. So the trial is not about the tool, the trial is about the implementation model. So we're really excited to hopefully get there. And with that, I think I will stop. I do want to just show my slides of my team, which are amazing people from Hospice Foundation of America and of course Penn State. There's many, many, many. And thank you.
Thank you. Yeah. And I forgot to mention, we'll hold questions for the end, so apologies. And I think your comment about the different types of the game in different population comes back to what we started the day off with.
Yeah.
Context matters, right? Yeah. So our next flash talk is by Jennifer Moss. Jennifer Moss is an assistant professor in the Departments of Family and Community Medicine and Public Health Sciences at Penn State College of Medicine. She also serves as assistant director of data analysis in the Office of Cancer Health Equity, the Penn State Cancer Institute. Dr. Moss received her PhD in health behavior at the University of North Carolina, Chapel Hill, and she served as a postdoctoral cancer prevention fellow at the National Cancer Institute with Dr. Adsul. I did not realize that. Fantastic. So Dr. Moss is a social and behavioral scientist focused on geographic disparities in cancer prevention behaviors and control. Her work examines aspects of the social and built environment that impact health and healthcare outcomes relevant to cancer, with a special interest in underserved and rural communities.
Thank you. Thanks all for having me here. I'm so excited to talk more, continue this conversation about implementation science. I'm going to share some work we recently completed examining the use of implementation science in programs implemented in rural settings focused on cancer screening promotion. And the reason we did this is we know that rural communities suffer from higher burden of screenable cancers compared to urban communities. But we have tools to prevent this incidence and mortality. So here's some data from a couple years back that I worked on while I was at NCI, examining disparities, urban-rural disparities in mortality from these 4 cancers. We have screening modalities to prevent all of these, or prevent mortality from all of these. But you can see that there's quite a difference across rural communities in terms of elevated burden from these cancers. Not so much for breast, but cervical, colorectal, and lung cancer. So how can we better get rural patients screened, get screening to those patients? We have evidence-based interventions, and they're not being rolled out at all. They're not being rolled out well in these communities. So we wanted to characterize the use of implementation science theoretical concepts in rural cancer screening promotion programs and identify needs for additional research. Long-term, this can improve the delivery of screening programs and ultimately increase cancer screening and reduce rural disparities. So both implementation focus and clinical outcomes focus. We also use CFER. It is a very comprehensive approach. And I've listed the 5. I call them domains, and then there are the constructs within each domain. So we have the intervention itself, the outer setting, sort of the social, cultural, legal, policy issues. The inner setting, which is the more local culture and resources, the individuals who actually deliver the intervention, and then the process of delivering the intervention. So we did a systematic search to identify studies reporting the processes of doing these interventions, and then we did a scoping review. So we, as I said, identified studies reporting cancer screening interventions in rural US communities. And then we extracted data from those manuscripts about were these constructs present or absent in the description of the intervention, and then more qualitatively, how were they applied for that program. So this is the PRISM model of how we identified our studies. We ended with 15 studies included in the review. These studies targeted people who are eligible for screening. So mostly they're looking at people based on age and sex. But some of these studies also targeted racial ethnic minorities or low income groups within these rural settings. They reached participants through clinics, communities, workplaces. There was a lot of diversity in terms of the method of outreach, as well as the specific screening outcomes. So we included studies focused on breast cancer screening, cervical, colorectal, and lung. And 3 of these studies actually targeted multiple cancers. You can see that about half of these studies, more than half of these studies, included breast cancer screening as their outcome. 5 included colorectal, 4 cervical, and 2 lung. So I'll sort of give an overview of all of our results and then talk about some of the key takeaways. So on the y-axis here is the number of studies reporting a given construct. Here I'm presenting the constructs for the intervention domain. So this is out of 15. You can see there's a lot of variability in terms of these constructs for how scientists talked about implementing these interventions. A lot of them discussed the adaptability of the intervention. When we look at the outer setting, there are 4 constructs here. Many authors talked about patient needs and resources and cosmopolitanism. And this is really how a given intervention setting is networked with other organizations, universities, political organizations, etc. The inner setting, there are quite a few constructs here. We see networks and communication, available resources really emphasized across these studies. For individuals, not nearly as many articles talked about these constructs. 0 talked about self-efficacy, but a few talked about knowledge and beliefs about the intervention. And again, this is the individuals delivering the intervention, not the individuals receiving the intervention. And finally, for the process domain, everyone talked about planning, and quite a few talked about reflecting and evaluating on the results and communicating that with their stakeholders. So in terms of the themes, what we took away from this sort of quantitative as well as the qualitative data was that these 4 constructs were pretty commonly discussed, as I pointed out in each slide. But there was much less discussion about the people, the inner setting. Attention for change in particular was a construct that nobody talked about. And this is really when program staff perceive a problem as untenable. It is unacceptable, and they feel like something has to change. This concept sort of waxes and wanes over time as patient needs change, as leadership priorities change, and program staff competing priorities change. Attention for change will increase or decrease, but when it's at a high point, that's a really great time to work with people to make that change. And then the other construct that nobody talked about was self-efficacy of these individuals. And again, this gets back to the program staff, the people who are delivering an intervention. Do they have, when leadership introduces an intervention, do they have the knowledge, skills, and resources that they need? They feel like they can address any challenge that comes up during implementation. So really the program staff, Dr. Adsul talked about this black box of what happens during an intervention. And I would contend that the program staff is a really key component of this black box. And we need to understand their needs and their processes throughout the implementation of an intervention. When we think about issues that are really especially pertinent in rural communities, sustainability is always going to be one. Keeping interventions simple and low cost, especially since there's limited tax base that can sustain an intervention after the research grant ends, right? And then the people are so paramount. The rural communities are really characterized by strong networks and interpersonal cohesion. And if you can win over the minds and hearts of the people delivering the intervention, you're going to be a lot more successful at rolling out the intervention, having an impact and a sustainable impact. So with that, I want to thank my co-authors and funding sources, and I guess we will take questions at the end. Thank you, everyone.
Hey, thank you very much. Our third flash talk will be by Gail. Gail's a final year Doctor of Public Health candidate, specializing in health services organization and policy at the Penn State College of Medicine. She's currently working on e-cigarette research and implementation science projects. Previously worked for the City of Hope National Medical Center, implementing a pilot lung cancer screening program in federally qualified health centers in the greater Los Angeles area. Prior to that, she facilitated research for the University of Southern California's Oncology Research Information Exchange Network program, initiated by the National Cancer Institute. She completed an MPH from Claremont Graduate University in 2018 and is a certified health education specialist.
Thanks so much. And thank you, Dr. Moss. I hope I can follow up to all of the wonderful talks that have just happened, so bear with me.
All right, so before I actually start, since we're all talking about our favorite frameworks, I'm gonna go ahead and throw a different hat in the ring, and I'm gonna say that my favorite is Sturman's frame. So I'm just gonna put that out there. But unfortunately, I am using CBER for mine as well. So don't judge me. I will be talking about assessing implementation and sustainability of best practice COVID-19 infection control in nursing homes today. And this is a study that I was able to actually work on last year. So very happy that now I'm able to present it to people as well. I'm just really quickly going to go over the background, methods, as I mentioned, CBER and implementation measures, results, and also highlight the implications for the study. So really quickly, the background of this study was nursing homes actually have been the center of COVID-19 infections and many deaths. And as we've seen in the past now, almost close to 3 years, as of March 13, 2023, and these are the latest numbers, we've seen more than 1.5 million total resident and total staff confirmed cases, more than 160,000 resident COVID-19 deaths, and more than 3,000 staff COVID-19 deaths. So clearly, infection control is an important aspect of being at nursing homes. There are many challenges to infection prevention in nursing homes, and nursing homes are actually required to have designated staff for infection control. Now, what we found was actually only 3% of designated infection control staff have actually taken a course on infection control best practices. So it is concerningly, so these deficiencies are concerningly common in nursing homes. And a recent study found that 82% of these surveyed nursing homes actually reported a deficiency in 1 or more years between 2013 and 2017. Now, the issue is that very little is really known about the implementation of these best practices in COVID-19 infection control in nursing homes, and especially during the pandemic. And so that's kind of like the basis for why we really wanted to do this work and the rationale for our studies. So we conducted 2 studies, and I will be going through both of them very quickly today in the interest of time. But our first study was looking at analyzing the implementation of COVID-19 infection control best practices in nursing homes, and we used 2 measures. So the first one was the CDC COVID-19 preparedness checklist. I will show you a snippet of what constructs we inquired about, as well as implementation science outcome scales. And the second study was discussing the integration of CBER and rapid qualitative analysis to actually provide actionable feedback to practitioners in the context of COVID-19 infection control in nursing homes. So before we get into the specifics of the studies, I just wanted to highlight what a nursing home echo would look like. And I know we've discussed, Dr. Adsul talked about, she highlighted Project Echo. We've heard about it today, but basically this is what a normal echo would look like. You start with your introductions to community building at nursing homes. That's an example of why we have these introductions. You move on to the brief lecture. It's a brief presentation on a specific topic, and in the context of nursing homes, specifically talking about infection control prevention, infection control. Then you have a nursing home case. So you'll have a clinical question, you'll discuss challenges and barriers. And then at the end, you have this case discussion.
which is essentially the heart of this session. So that's where you really get to connect with other professionals, discuss and have more collaborative problem solving with regards to the case. So for our first study, these were the methods. We actually surveyed these nursing home administrators, and we did that twice. So once at baseline, which was December 2020 to February 2021. And then a 6-month follow-up to June, from June to August 2021. The two measures, as I mentioned earlier, the CDC COVID-19 preparedness checklist and these implementation measures were used. And our demographics, or the people that we that responded to our surveys, were nursing home administrators, but they were also registered nurses, infection control preventionists, executive directors, so kind of like almost a broad range of people that we were able to serve. So as I mentioned earlier, this is just a very quick snippet. These were the different constructs that we highlighted. We asked questions about preparedness, visitation policies, communication with family, the education, did they get enough information about COVID-19, with regards to the staff as well as the residents. So we're looking at both aspects here. We also inquired about COVID-19 infection control practices among the staff and residents, potential resident cases, hygiene practices. So wide variety of questions from this preparedness checklist. And the implementation scales, this actually was an evaluation, and it included 6 different types of measurements. So you have this practice adaptive reserve, organizational readiness for change, organizational climate measure, implementation climate assessment, generally just looking at how does implementation play a role in how infection control was carried out at this nursing home or at the many nursing homes. So these were our results, and this is specifically from the CDC checklist. So as I mentioned earlier, we saw a lot of differences, and these are mainly the specific constructs that we saw significance or a difference in. So for example, as you can see, visitation policies, initially, they obviously restricted a lot of people from the building, but over time at 6 months, they kind of had loosened the restrictions. Moving forward, communication with family members, we saw a little bit of a difference there. Infection control practices among the residents before they had actually stopped communal dining because of COVID-19, and then over time, how they were able to actually loosen those restrictions. We did see a lot of differences, and that was really exciting to us. With regards to the scales, we actually did see only one difference, and that was in the organizational readiness for change. And what that essentially means is that in the context of COVID-19 infection control best practices, we saw that they were essentially more ready and more open to actually making those changes in infection control best practices at their nursing homes. And moving on to our study 2, we actually conducted in-depth interviews with randomized control participants. We had these virtual interviews between June to September 2021, and they lasted about 45 minutes each. The interview guide consisted of CFIR questions. So how does the intervention compare to other infection control training that you have participated in or that you know about? So we're asking them to compare in their minds about and tell us how did they think that we made a difference in terms of this this intervention. These interviews were audio recorded and transcribed, and the coders did use the rapid qualitative assessment techniques to summarize these transcripts. So these were our results. We actually found that there were changes, and what I've highlighted here are in bold are the CFIR constructs. So external policies and incentives. They could either facilitate or they would slow down implementation of best practice guidelines. So one example was excessive reporting. And I just want to highlight here that this is just a snippet. We actually actually have so many quotes and so many more different constructs. But we just didn't have enough time and space to share all of that with y'all. But similarly, we saw that nursing homes reported high levels of readiness for implementation and leadership engagement. And as actually Dr. Moss talked about cosmopolitanism from her slides, our participants appreciated that Project ECHO provided that access to knowledge and information and created that learning environment after they participated in the ECHO series. And similarly, it reduced practice isolation because of that. Finally, implications for D&I, integrating CFIR through the RQA was actually very helpful for evaluating implementation of best practice COVID-19 infection control in nursing homes. We also found that participants really valued Project ECHO, and they really valued it in terms of an implementation strategy. And I think that's very important. And as we've been hearing today, that we have to really look at the context and see what people really need in that context. And in this context, they really value that. As Dr. Adsul said, it takes a village. So I would like to thank my co-authors and especially Dr. Jen Krishnowski and the CTSN team for having us here, for us being able to help with this work, as well as our funders, PCORI and AHRQ. Thank you so much.
Thank you, Gail. And I think I'm going to stop sharing this slides, right? Okay. So our fourth flash talk is by Sarah Chalensky. Sarah Chalensky has worked in prevention research and evaluation for more than 20 years. She became interested in the field after working with children, led her to question the role that communities play in youth development, and how community programs can be a source of support for those in need. As an associate research professor at the end of Bennett Pierce Prevention Research Center in the College of Health and Human Development at Penn State University, Dr. Chalensky focuses on how communities, schools, and universities can collaborate in the pursuit of quality youth prevention programming. Her current applied community research projects focus on community collaboration, technical assistance for community coalition models, supporting public health, dissemination of evidence-based programs and sustainability, and community context-related youth outcomes. It's good to see you, Sarah, and thank you very much.
Great. So should I share my own slides from here?
Yeah, are you able to do that?
Yeah, I should be able to. Yeah, just let's see here. Okay, do you see the presentation?
Yeah, that's perfect.
Great. Well, I've enjoyed the presentation so far today. It's really clear that these implementation science and implementation dissemination themes cut across the continuum of care. And so I'm actually going to take us to the prevention side of that continuum of care and talk a little bit today about the Coalition Checkup Project. And so it's a project that I developed with Lewis Brown and many others at both Penn State and Texas, UT Health. And it was funded as an R01 by NIDA as a hybrid type 3 effectiveness and implementation trial, where we're randomizing 68 community coalitions for this, to go through this experience of technical assistance. Okay, so let's see here. Okay, so first, what are community coalitions? What are these community prevention coalitions? Well, a community prevention coalition is a group of individuals and organizations that come together to make decisions about, to implement, and evaluate youth health related programs and activities. And so often these groups organize around issues preventing adolescent substance use. And so that's the area that most of my work is in and that we're talking about today. And so in that area, so what do we know? We know that in the area of youth development and family well-being, which includes adolescent substance abuse prevention, we know that community coalitions often, well, different types of community coalitions have evidence of supporting high quality program implementation and dissemination of evidence-based programs, and also better sustainability of those programs. But we still know that dissemination and sustainability of evidence-based programs and policies and practices and treatments still remain a challenge for the field. You know, sustainability is long. It's not 1 year, 2 years, the course of a study. We're talking about a lifetime and then some, if we're really talking about sustainability. And so yet, if we are really looking for a long-term positive shift or improvement in public health, an improvement that is truly sustained for the long term, sustainability, yes, remains challenging. And so there's much turnover in human services and social services. Schools and other youth serving organizations are constantly looking for that best new thing. Oftentimes in communities, it's easier to get seed money to start up something new, try something new. People frequently are still looking for an easy and quick fix. You know, that was a theme I heard earlier as well. And so in my field, in the field of prevention, that's often an assembly or a parent info night or some sort of one-shot deal. You know, I'm going to take kids to a prison so they can see what happens there, right? So a quick one-shot deal. And oftentimes those programs and policies with the strongest evidence are more complicated. Another theme, which I heard earlier today too. They take more time and they take more resources. And though the evidence is pretty clear that technical assistance and other support is necessary and helpful, there is a lack of knowledge as to what kind of support and assistance is actually most beneficial. And so that brings us to my favorite dissemination and implementation theory, which is the interactive systems framework. And so my colleagues and I are drawing from Wandersman's interactive systems framework for dissemination and implementation. And so to this work, we bring, well, and so just, so quick pause. So in this interactive systems framework, it's recognizing that programs are delivered in a delivery system. That's where the prevention or programs are implemented. But then there's the support system here, or the system here that can support the delivery of programs. And yet there is the broader field of the prevention synthesis and translation system, much bigger picture. This particular study is focused on the prevention support system and that prevention delivery system. And so to this work, we bring the question, you know, can we create a low cost, a relatively low intensity technical assistance system that enhances that prevention support system and thereby increases capacity for evidence-based program implementation and then thereby decreases adolescent substance use. And so we're trying to build an evidence base for a scalable technical assistance model that indicates how to intervene with community coalitions to maximize evidence-based program fidelity and sustainability. And I'm just looking at the time. I know we started a little bit behind, but how much more time do I have?
About 3 minutes.
Okay, got it. And so here, the coalition checkup here is kind of placed then within that interactive systems framework. And so the 4-step process of the coalition checkup is here embedded within the prevention support system. And this work here, we expect to impact both the capacities, the evidence-based specific capacities, and also general capacities that will affect program implementation down the line to affect youth substance use. And so what is the coalition checkup? In the big picture, it's a data-informed, relationship-based, and coalition-driven system of support for supporting community coalitions. It's based in what's probably a pretty familiar data feedback system, where we first gather information from those involved. We put it into a user-friendly report where that goes quickly to the coalitions and their technical assistance provider, where they review what's given to them, they assess their strengths and potential areas for growth. They make selections over what their priorities are and what they want to work on that will most likely have the greatest impact in improving their prevention services and delivery and programs. And then they implement that action plan. And then it goes back to gather more information. And so we're still in the process of implementing and gathering data and also running analyses. So I'm just going to focus a little bit or share just a few dissemination and implementation measures. All of our, this whole study obviously is a dissemination and implementation study. And so thereby we're studying both the prevention delivery system here, have implementation quality measures of the prevention delivery system, and then dissemination and implementation quality of all those community improvement activities. And so I'll just touch on these measures of evidence-based programs. So we're getting measures of every program policy activity that are connected to coalitions. And so with every policy program activity, we are coding their level of evidence. And then also a couple particular measures of evidence-based program, their quantity of programming, the quality of their programming, and also the sustainability of their programs. And you can see here a little bit of how those measures are being put together. Then, of course, the sustainability planning as well. And then those measures were specific to the programs. When it comes to policies and activities, we're not able to get as much information in depth for them, but there is then, we can still code that level of evidence and their reach, still an element of implementation quality. And I'm going to stop there today and skip ahead and just share my acknowledgements. Thank you so much.
Thank you very much. So we don't have a lot of time, but I think we have a little under 10 minutes maybe for some questions for any of the Flash Talk speakers. If you're online, please put in the chat, and I think Erica's going to check it, and then anyone here in the room.
I have a question. I think we talked a couple of good things here about implementation in community settings. Some of you have been working in both places, clinical settings and the community. I think Priyanka, you mentioned about this example about the ham and the turkey. I think how we can take these ideas about social needs and integrate that into our actual implementation projects. What ideas do you have like that one to move implementation science to those community settings in your own work, rural settings, nursing homes, probably in your own work? LJ, what ideas do you have maybe to facilitate that transition process? You can
jump in if you have anything.
Yeah, sorry.
Oh, yeah.
Yeah, I mean, our approach on our team is to really listen to our stakeholders and our hosts. And so, our hosts provide a good amount of data and ideas as to how to come up with creative ways to do these kinds of things. For us, it's really more about the delivery of who is delivering our interventions. And so that's sort of our creative way. We're using, priests or rabbis or just people from the community that wouldn't normally be. It's sort of like the barbershop model, right? For African-American prostate cancer. That was one of the, I think, pivotal community engaged studies. So, our strategy is really to let our communities be flexible and not have one delivery approach for every community, because one size doesn't fit
at all.
Maybe as from Jennifer Moss or.
So I will say, this morning I was at, CGSI was sponsoring another event in Northern Dauphin County, which is much more rural and underserved. And I was just blown away by the number of people from the community who are already doing the work, who are already committed to identifying the social needs and trying to meet them. They're outside of academia, they're outside of government, certainly. And I think those, you know, several times people have talked about the partnerships and the community, the people and the community, and there are already people in these communities who are doing the work. And I really like Sarah's information about the coalition check-in, like how can we support what's already been being done in order to better serve our communities.
Yeah, I wanna follow up on that comment, probably for that, we're playing here. Sarah Cholinsky can just come in here. What in your opinion, you're doing that coalition work, what in your opinion is the best strategy to involve community organizations, community partners, to get excited about the job that we're doing in academia, to probably move our interventions to those local settings?
Yeah, you know, it's really been interesting. One thing that NIDA, one reason why this study got funded is because NIDA was interested in a generic model that would support all kinds of community coalitions. So we know that some types of community coalitions, those with evidence-based programs that implement evidence-based programs and are supported by TA, that those are the ones that have impacts on youth outcomes. But we also know that there's more than 5,000 community anti-drug coalitions already existing in the United States, and most of them don't implement evidence-based programs. And so, so we're working through that with the coalitions right now. And what seems, you know, we're doing these analyses, what seems to be surfacing is that using this kind of a data-based, data-informed, relationship-based, coalition-driven approach here, it is helping the coalitions take a more data-informed approach to decision-making. And then that, I think, will eventually impact their willingness and interest in connecting with those evidence-based programs. Those that already see it as part of their mission and vision, they're already doing it, and they can do it better, certainly. And so we think this intervention will help with that. But those that aren't doing programs already and don't see it as part of their mission, that's where we think it's going to be a little bit slower of a process, but hopefully sustainable.
All right, yeah, one more question?
Yeah, we have time, yeah.
Okay, one more question, last question, then I'll let everybody go so they're on time. To the point of one of the presenters, people are paramount. In many of these presentations, nurses were present and active in the communities. Often they were trusted persons who could connect to people in communities. Have any of you looked at the roles of nurses specifically? And then also what they need in order to improve upon the role they provide within communities to maximize implementation of data?
I can give an example of that. I didn't know personally about that work today, but I have been doing amazing work involving nurses and practitioners and other people like PAs and MAs as vaccine champions. And champions is one implementation strategy. You know, how you outside the usual physician, you put that other cast of other people who can support implementation. So that's one strategy that I have been involved with other people at UNC, and hopefully we can have other healthcare professionals involved in those efforts. So at least that's my experience and all people in the audience here.
Yeah, I will say now nurses are like the #1 trusted profession, right? They've surpassed physicians, and they're such a key stakeholder in the community, both as community members and as interventionists. What I think we're seeing, at least in the family medicine department, is that there's more and more responsibility for nurses and their capacity to take on additional responsibilities is getting less and less. So I was really interested, Gail, in your data about capacity for change has increased. And I wonder if, or organizational readiness for change. I wonder if you measure that again now with the, you know, the workforce issues that every healthcare system is facing, if we would still see that same improvement.
So just to highlight a little bit on that, actually, we did see a decrease in responses, and that was, we felt that was mainly because of staff turnover, it was COVID, there was a lot of changes happening. So going to your point, there is so much more that we can do in terms of bettering that, but the change in 9 months, 12 months, I mean, we would have to follow that up with another study and see what would happen then. But it is difficult, and what Dr. Calo was talking about with regards to that study that we're doing, where we're looking at champions and nurses serving as champions. We definitely are interested in seeing what the impact of that is in the future with it.
Okay, thank you, everybody, for your flash talks. I'm going to turn it over to Dr. Calo to give some closing remarks.
Thank you all for those of you who have been staying with us these 2 hours. I just want to mention a few things about what we're trying to accomplish as part of this seminar series and other things. This seminar is part of the Implementation Science Core, and as I mentioned before, we want to build capacity among faculty, trainees, and community partners to apply implementation science to advance the use of evidence-based practices and interventions in both community and clinical settings. As part of ISC, or Implementation Science Core, we offer some services and resources at no cost, and this is provided through CTSI. So we offer no-cost consultations to support your projects and also run applications. We have a work group that is very active, developing a shared agenda for implementation science for the entire College of Medicine. Let me know if some of you would like to participate in that. We have our second meeting next month. Mentioned the implementation science seminars. We want to provide education and training. Some good news. We plan to have our second seminar like this one with a guest speaker and more flash talk from our faculty happening late August, early September at University Park in collaboration with SSRI. So stay tuned. You will get more information about that. We're in the planning phases for that. So depending on the topic, we will have new speakers and new flash talks. So we will see you very soon at University Park. And the last thing is that good news, we have a new program. It's the ISC Faculty Fellowship coming very soon this summer, and we'll provide 1-year training and mentorship network to faculty interested in advancing their implementation science expertise. You will get an announcement very soon for this. Very similar to the CTSI Cert Fellowship, we'll offer some course buyout for 10% FTE cover for that faculty. We expect to have more people, but at least next year we'll start with only one faculty. So hopefully we can get some applications when we release that announcement very soon. This is a consultation, as many of you know. Please go to our CTSI website. There's a button there that you can read this consultation, not only for this, but also for CERT, BERT, and other services that we can help you. With that being said, I just want to say thank you so much. This was a great experience having Dr. Prescott here. Many of our amazing faculty giving flash talks, and people just told me that between the room here and soon we eat over 85 people. So it was a great experience. So stay tuned for our second one very soon. Thank you.